Welcome everybody to our Best MSK Health Programme launch. Firstly, our apologies for the slightly delayed start, but believe me, it'll be worth the wait. And we've got a beautiful lineup of presenters with Professor Tim Biggs, Chris Mercer and Andy Bennett, who will take you through the shaping of the new MSK programme. So we plan to be here for about an hour and we hope that you'll be able to stay and join with us. There's a couple of ways you can engage with us. So using the chat box, which should be down the right hand side of your screen. It's a Q&A type box. So add in your details. We'd really love it if you could put your name in rather than anonymous. And that will help us also to see who's involved, who's engaged. And we'll be replying to those comments during the session, but there'll also be a question and answer at the end. So very much looking forward to this session. And next slide, please. So our team for today is as supporting Andrew, Chris and Tim are Jane, who has done masses of work behind the scenes to make this day happen, and thank you to Jane for that. My colleagues in Horizons, Rupal and Kerry, who are flying the plane, as they say, and myself, Bev Matthews, who will be navigating you through the next hour. So next slide, please. So our first presenter today is Andy Bennett, who's our National Clinical Director for MSK Conditions here at NHS England and NHS Improvement, consultant physio at Sutton Health and Care Alliance and Epsom and St Helier NHS Trust. Do welcome Andy to the stage now, and we'll move on to the first slide for Andy around the MSK vision. So Andy, welcome, and over to you.
Thank you, and hopefully everyone can hear me okay. I'm not sure, I pretty much think people can't see me, which is a good thing, because the old lockdown hair is not looking very good, and it's certainly got greyer over the last half an hour, I think it's fair to say. So thank you for your patience for waiting, and thanks for attending this this launch, which we're really excited about. I think also I'd like to say thanks to all of you right across the MSK community for your hard work in the context of the multiple challenges we've had within the last year in this pandemic. And those are not only professionally and occupationally, but those challenges we've all experienced personally as well, not to mention the IT challenges that we've all experienced and certainly we've had in the last half an hour. And thanks to Jane and our Horizons team to try and navigate us through. So look, I have the great pleasure to launch what is our new Best MSK Health Programme, and sort of share our enthusiasm regarding the opportunity this brings for the MSK world in the context of restoration and improvement. And it's great, we've got following me Professor Tim Biggs, who's going to provide an overview of the challenges and opportunities facing orthopaedics, followed by Chris Mercer, consultant physio, talking about similar challenges and opportunity in the primary and community care setting. This is obviously, I think, still going to be recorded, and hopefully we'll be able to share the link on social media. There is also a hashtag we'd like to use as part of this programme, which I'm aware is not on this slide, but it's hashtag BestMSKHealth. So please feel free to chat, talk, and engage in this so we can build it collaboratively. As said, Jane, our excellent programme lead, is fielding questions in the chat box. I'm unable to see those because I'm doing this over my phone, so I'm sure we'll coordinate those for next for our chat at the end. So the slide, hopefully you can see, relates to the MSK vision. And about a year ago, prior to the onset of this pandemic, new to the role as MCD, we put together this vision for MSK, and that is to promote best lifelong MSK health within all communities. And what we mean by that is MSK health enables physical activity. And if we can enable people to be mobile, dexterous, move their limbs, we can help people work and participate in all aspects of life and have economic, social and functional independence. And of course, the knock-on benefits of physical activity are huge to all-cause mortality. And if we can help people be active and have good MSK health, people can grow well, age well, and work well and age well and live life to the full. Next slide, please. And so hopefully you can see a slide with MSK AIM on it. And our overarching aim is to sustain the delivery of evidence-informed, personalised, high-quality, integrated healthcare value to all. And there's loads of buzzwords there. Essentially, from an evidence-informed perspective, what we do needs to be informed by research, and research needs to inform what we do. But it's about integrating research, evidence, expertise, and experience to drive forward our provision. We want to deliver personalised care where users and people have choice on how their care is planned and delivered based on what matters to them, and shared decision making is a key element of that. We want to deliver high quality care defined as safe, effective, and associated with a positive experience for all involved. And that needs to be care that is valued by all. And we traditionally think of economic value related to our resources, and but we also need to think about social value and have a MSK provision that everybody values and everybody sees the benefit of. Next slide, please. And we want to deliver integrated care. So what do we mean by that? Well, we know that musculoskeletal conditions are broadly driven by factors across a biopsychosocial framework unique to the individual. And the majority of musculoskeletal conditions can be managed very, very well in primary and community care. We need to get a small number of conditions, patients into secondary care at the right time for the right intervention. And we need to envelope this with the right rehab to help those individuals get back to being physically active and living life to the full. And given that the musculoskeletal conditions are driven by these multiple biopsychosocial factors, we need to work closely with social care services and mental health services to help achieve this vision and aim. And this is an overarching model which we can hang on guidance and pathways to inform our provision, and hopefully achieve the ambition of helping people grow well, work well, and age well. Next slide, please. So we put this all together back in January and February last year, and then we used this strategy and this integrated model to try and coordinate our initial response to the pandemic. So back in phase 1, we quickly convened a group, an MSK COVID group in NHS England, made up of key stakeholders in the MSK world, the BOA, the BSR, the CSP, Versus Arthritis, ARMA, and colleagues from PHE and HE. And our focus was to support surge capacity, maintain urgent emergency pathways, and reduce transmission. And what we wanted to do was make sure that the messaging we were putting out, the guidance we were putting out in a very challenged context, aligns with this concept of integration. So what we were saying in primary and community care within the community operating procedure and our messaging to primary care colleagues aligned and was coordinated with what we were saying in secondary care in our specialist guidance regarding trauma, orthopedics, rheumatology and spine. And the MSK COVID group enabled that. It enabled a coordinated approach between multiple musculoskeletal stakeholders, and we brought this together and made sure this all aligned, and we delivered a significant amount of work in a short period of time. Next slide, please. And we took this collaborative approach forward and this integrated approach forward as we moved out of the first phase. And this helped develop our beneficial changes project, which many people would have been involved in on this call, I'm sure, where we look to identify those things, those ideas that had been rapidly introduced in the context of COVID that were helping services work in a different way. And through the beneficial changes project, working closely with ARMA and Versus Arthritis, we developed a co-productive approach to our MSK strategy, bringing in patient representatives and developing a themes of what matters resource, where we engaged with our colleagues through ARMA, with the charitable groups and through Versus Arthritis, as well as those with lived experience, to really work out what matters to people in the current context to drive our strategy moving forward. And so what we built within a 6-month period is key beneficial changes related to an integrated approach and viewing MSK not in silos within specific areas, like specific pathways or domains, but across a broad scope related to triple integration. A collaborative approach where the MSK community at national level came put together in a wonderful way to deliver advice, guidance and task and finish roles. And a co-productive approach where we're working very closely with colleagues in the third sector, charitable sector, and those who lived experience to build our strategy. And what came of that was acknowledgement in the NHS England letter produced just before Christmas, reflecting the operational priorities for winter in 2021-22. And it was recognised that in the context of restoration and improvement, there was significant value that could be brought in a number of different services: ophthalmology, cardiac services, and MSK and orthopaedics. And with that, we've had the opportunity to put together, to build a programme for MSK delivery, to take these overarching beneficial changes of integration, collaboration, and co-production forward with resources and a structure to help not only support the restoration challenge, which is significant and ahead, but also to try and improve the quality and value of MSK conditions nationwide. Next slide, please. And so we've conceived this Best MSK Health programme, which sits within NHS improvement. And what is our challenge within this programme? Well, we had challenges pre-pandemic. We had a challenged MSK system with rising demand, constrained resources, and increasing complexity. I think it's fair to say we had unwarranted variation commission, access and delivery, and this creates services that are complex, fragmented, and variable in quality and value. And this was driving inequalities in MSK health. We also have unintended consequences of the pandemic. The pandemic has affected everybody from a biopsychosocial spectrum perspective and affected everybody's health and well-being. And this has created an increased complexity in the presentation of MSK conditions that we are seeing. We also know that waiting times have been significantly affected by the need to pause planned care to support a response to the pandemic. And taken together with the changes, we knew that the challenges in place pre-pandemic, there is a huge potential for widening health inequalities. But also we've got beneficial changes, and those beneficial changes of integration, collaboration, and co-production. And from an MSK perspective, we are in a far different position, and we have a significant opportunity that we didn't have a year ago. And as we move out of this current response phase, aligned with the potential benefits of the vaccination programme that is progressing exceptionally well, into a restoration of services phase, we have the opportunity through this Best MSK Health programme and recovery to improve the quality and value of our provision and to enable Best MSK Health for all. Next slide, please. So MSK is a broad sphere. And reflecting on the operational priorities later, we talked about MSK and orthopaedics. What do we mean by MSK? Well, we've split MSK into sort of two directions. Firstly, we can view MSK based on clinical domains. So first, we need a wraparound preventative approach to what we're doing. In MSK, we are trying to enable people to be active, have good diet, maintain good mental health, cessate smoking and moderate alcohol. There is, of course, a primary prevention role which PHE are focusing on, but essentially triage, long-term condition management, and getting the right patient in the right place at the right time is good secondary, tertiary prevention. And we need to take this overarching preventative approach to our MSK strategy. If we think about clinical domains, we have triage provision, and that's all points of access for MSK. In primary care related to FCP and GPs, and community care with single point of access services. But we also have MSK patients presenting through ambulance services and urgent emergency care. Also in primary and community care, we have a significant challenge with regard to long-term condition management, supporting rehab, and of course in the current context, rehabilitation. We have diagnostics, which is transitioning more into primary and community care with the outcomes of the Richards report. And then we have secondary care, where we have planned rheumatology, orthopaedics, spine and pain management services. But we can also define MSK conditions across a clinical domain and a condition domain, and that's reflected in this sort of inverted y-axis, where we split MSK conditions in mechanical conditions and OA over 45, and that's where our challenges regarding hips, knees, shoulder pain, carpal tunnel sits. We've got spinal conditions, which is certainly the most prevalent presentation to primary and community care. MSK encompasses rheumatology, and we've got challenges with regard to inflammatory arthritis and autoimmune connective tissue disorders. We've got osteoporosis, falls and fragility fractures, which overlaps the ageing agenda and also the trauma agenda. And also we have the challenge around widespread pain and fibromyalgia, or chronic primary pain. The terminology varies. And so we've tried to orientate and define and delineate MSK using this matrix across these clinical domains, focusing on the need for an integrated model of delivery, and then within pathways that are condition specific around mechanical conditions, spline, inflammatory conditions, osteoporosis, and widespread pain. Next slide, please. And so the challenge is to take the opportunity a program brings, which is resource and influence, and to try and formulate work streams and a strategy to restore and optimize elements of MSK care linked with that matrix. And so we've had the opportunity to form 10 different work streams within this MSK program. This relates to restoration optimization of diagnostics, orthopedics, rheumatology, primary community care and spinal services, also falls, fragility, fractures and osteoporosis. And those are led by our GIRF leads, including Tim, and also other clinical expert specialists in the area, such as Chris, who is speaking later, who's leading our work on the restoration optimization of primary and community care. We've also got enabling work streams. We have significant challenges with regard to data, validation and coding right across the framework for MSK, from primary through community to secondary care. We want to look at how to communicate and engage the MSK world and in this work. Now, there is the traditional top-down approach through the regions and the ICSs linking with the PCNs, which is key. But also there is the bottom-up approach as how we as an MSK community can engage with this and really feel ownership in delivery of these changes. And then also what I'm very excited about is we've got a work stream related to specifically to supporting those with long-term MSK conditions. And we have the opportunity for a national speciality advisor role in personalised care, focusing on MSK, which is going to go out to advert in the next few weeks, whose role will be to drive our strategy, which is a key enabler for the work right across the MSK framework to best deliver that support that people need to best manage long-term MSK conditions in the community. Next slide, please. And so with this program and those work streams, we have key drivers. We want to ensure that the program is co-produced. We want to ensure that everybody in the MSK community feels engaged and part of this strategy to recover and improve services. We need to enable local leads who have the best understanding of population need and local resources to drive our restoration and improvement. We want to optimise local integrated delivery models aligned with the principles of triple integration as discussed, accepting that models vary and one size does not fit all, and we need to enable local leads to adapt principles around integrated delivery to best meet the needs of the population. We need to hang evidence-informed condition-related pathways and guidance on these models to help ensure that we're delivering the best quality and value of provision. This relates to urgent and emergency conditions, diagnostics and planned care, working very closely with GIRF, building on the excellent work done in London, which Tim will talk about, but also the effective commissioning work and other guidance that's out there. We want to really focus on how we can best support people to best live with long-term MSK conditions. And as said, I'm very excited about the opportunity to work with personalised care on this. We have a significant challenge regarding digital enablement, which I am sure we have all experienced in our time working in MSK, and we want to try and see if we can optimise that. And of course, we need to measure quality and value and impact of the work we're doing right across the model, from primary to community to secondary care, to ensure that we're aiming to achieve the top quartile of performance. And that is absolutely key, because the challenge we have ahead is significant in terms of restoration. And that challenge relates to balancing risk, demand, capacity, and ultimately productivity. And productivity can be viewed as a cold word, and it can be viewed as just working harder, and it's not. What we need to do is try and work smarter, maximise our resources to the needs of the population. And I think we can do this if we take this approach regarding optimising the model of delivery and then applying pathways and guidance on top of it. Next slide, please. And so what's the ask? So this program is at the point of inception. We are 2 or 3 weeks old. We are developing this as we go. And I think as we've experienced from our IT challenges, it's not going to be simple moving forward. What we don't want to do is come to you all with something done that we want you to apply. What we want to do is take this program forward as a collaborative and to sustain those beneficial changes of integration, of collaboration and co-production. This is an opportunity for all of us in the MSK world, commissioners, clinicians, patients, carers, to try and really restore and build a service that we all value and that will help deal with the significant challenges we have ahead, but also make the best use of the beneficial changes that we've experienced in the last year. And this is a fantastic opportunity to do that. So the ask is to keep your ears on the ground and to get involved. We are going to be using the Change Challenge site again in a very different way to help share ideas and develop an MSK community. We're going to be using the Futures site to share things, and we are going to be delivering more webinars and events around this program and around the specific domains and condition-specific pathways. And so I hope everybody can engage in that and get involved in that and help us build this program collaboratively to achieve our aim of delivering the best quality MSK health for all that everybody values greatly. So once again, apologies for the technicalities we've experienced. I hope that synced and the slides fitted with what I was saying. And I will take a step back and pass the proverbial mic over to Tim to introduce the specific challenges and opportunities we have in orthopedics. Thank you all.
So good evening. First of all, can everybody hear me?
Yeah, perfectly, Tim. Perfectly.
So can we go to my first slide, which is the title slide, Getting It Right First Time, the challenge in orthopedics?
Yep.
Lovely. So thank you very much indeed for that, Andy. And I have to say it's been an interesting experience this evening getting here, but here we go. And can we go to my second slide, please? As many of you will know, that the GIRV programme is now embedded in the long-term plan to make sure we don't reduce waste, increase time to care, and also we want to reduce unjustified variation in performance. You will also know, next slide please, that GIRV is delivering at a national level. We've had 12 national reports to date. Orthopedics was the first, and we've just had 10 now published on top of that 12, and we'll have a total of 38 published by July, August of this year. Next slide, please. This all started for me in orthopedics because I work at the Royal National Orthopaedic Hospital, and I was seeing patients like this coming through to my clinic where they'd had a number of operations which I think could have been avoided if things had been done in a different way. And here's an example of a 48-year-old female who's already had her right knee revised twice after the primary, and after, on the left side, she's had half a knee done, and by the end of the first year, she needs the other side doing as well. Next slide, please. So the GIRV programme was making sure that we needed to do something different. It was a quality improvement programme led by clinicians and empowering clinicians, I have to say, to actually improve the quality of care that we deliver to our patients. Next slide, please. We were the first people to get 12 sources of data together into a pack, and then what we did was we sent them out to the hospitals, and then I, as the lead clinician in orthopedics, went to visit them. And I was very lucky at the time that I was president of the British Orthopaedic Association, which gave me a mandate for the membership to try and drive change. So what did we find as an example of when we started this programme in 2012-13? Next slide, please. So here's an example of what was going on around knee replacement. And if you look at the area that I've circled in red, look at your half knee replacement, we know that if you do low volumes, your outcomes are not as good. And when I went round initially, the commonest number being done by orthopaedic surgeons in England was 1. Second commonest number was 2. But you can see here that 75% of surgeons were doing less than 10 a year. And I would ask anybody on the call, is that acceptable? Next slide, please. This is a large city in England, they have 10 trusts, and just look at the variation in infection rate in the same city between different trusts. As low as 0.19% anywhere, that is as good as anywhere in the world. But then look at Trust 5, where it's 4.49%. If we could reduce it to 0.2%, which Trust 10 can, then you'll be saving 250 to 300 million pounds a year, as well as saving many, many patients from the misery of having problems with knees that are infected, because we know it's a disaster. Next slide, please. So what did Girth do and manage to do in orthopedics? Well, it's done quite a lot, really. We've seen a reduction in length of stay for hip and knee replacement, the right implants being used in the right patients, use of ring-fenced beds to make sure we reduce the infection rates, reduction of inappropriate operations, the low-volume surgeons stopping and changing practice and referring those patients on, and we've seen a reduction in readmission rates at 30 days. The revision rates for hip and knee replacement has dropped year on year, and we've seen a year-on-year drop in litigation, and orthopedics, which was the most litigated specialty and represented 10% of all costs, is now number 2 and represents only 5% of costs. So we know that we've saved roughly £145 million in the last 5 years by just reducing litigation in orthopedics alone. We've also seen reduction in loan kit costs, reduction in costs of hip and knee replacement, and all that improves outcomes, squeezes out unwarranted variation, results in freeing up bed capacity, getting it the right patient through the right bed at the right time, and frees up theatre time because we're doing the right cases, and therefore we could do more. Next slide, please. The problem, though, is that Girth was voluntary. And so if a trust didn't want to engage in the Girth programme, despite me visiting this trust on 3 occasions, just look at their outcomes. High revision rates for hip and knee replacement, some of the worst in the country, long length of stays, high readmission rates, and poor outcomes. Now that reflects very badly, I would say, on the profession in the trust, but also the managerial teams, because we're not providing the patients with the care that we should. Next slide. Now, then came COVID, and I think that has been a game changer for all of us. First of all, we saw a huge drop in the elective activity, and if you look across the regions, it was about the same percentage in all the regions, but London was most profoundly affected in wave 1, and by the 11th of April, we're at about 11% of business as usual, the worst performing region in the country. So I was asked to get involved by Sir David Sloman to help transform, from the clinical point of view, the clinical, how we could transform clinical services. So where are we now after wave 2? We've got anywhere between 250 and 300,000 patients waiting more than 52 weeks. We've got 5 million on a waiting list, and of that, orthopedics is 572,000, and waiting more than 52 weeks is almost 50,000. So we've got a massive problem. Next slide, please. So what we've done in London is, instead of looking at the individual hospital level, we are looking at the system level. So everybody will know that we have now 42 ICSs or STPs around the country. We're looking at population health, and in London we have 5 ICSs. We decided that we wanted equity of access and excellent clinical outcomes for the population. So average is no longer good enough. So what we've driven for is the top decile of the Girth metrics in terms of performance, and that is what we consider to be the new norm. We wanted high productivity, and to get to the top decile, we've asked each ICS, each system, to fill in there where they are in relation to the between 10 and 40 metrics about that's going to put them in the top decile, and now they have something to aim at to actually get there. The other thing we've done is, the first time in the history of the NHS, we have standardised pathways and procedures across 6 surgical specialties, one of those being orthopedics. And it's also, this was prepared by expert advisory panels, and just to show the groupings we had 200 clinicians on the first call. And we also decided to set standards of theatre productivity, 4 joints on an all-day list, 10 cataracts on a half-day list, and also setting the fact we've got to start our theatres on time, finish on time, and also turnaround times have to be appropriate so we can get through cases. Next slide, please. So this is the orthopedic gateway, where I've got the red rectangle shows what we're aiming for, and this London system has put down where they are. But the first time they now have something to aim at where they're going to get to the top decile of performance. Next slide, please. This is the 6 surgical specialties we looked at initially. We called it the high volume, low complexity group. And you'll see that in orthopedics, we've also encompassed spines. So you can see there, we've got 11 pathways. And the pathways were developed by clinical groups, and they developed the 29 pathways in 7 weeks. Absolutely phenomenal. And they've now been signed off by the Royal Colleges of the specialist societies. And you can see, next slide, please, that they demonstrate the whole pathway, not just the secondary care part, of which I'm involved in very heavily with GIRFT, but also we go back to primary care, the part where Andy's really heavily involved in, and also as we go downstream into community discharge and therefore follow-up. So it's very important we bring it all together. Next slide, please. In London, we developed hub sites that we could focus on doing the high volume, low complexity work really well. And the question is, has that been successful? We also set up day case rates. So it's quite clear across the capital that day case rates were not uniform in terms of the percentages on procedures. And what we aim for now in orthopedics is we want about 85% of all surgical procedures to be day case rates. Next slide, please. So if we get this right, so what can we expect? So this is London, this is the data, and if we get to the top decile of the GIRFT metrics in London on 1-year readmission rates, 30-day readmission rates, day case length of stay, etc., that would be the equivalent of freeing up 83 beds. And you could put through an extra 7,000 new hip and knee replacements through the same facilities at no extra cost. And in addition, if you do things well, you'd see a significant drop in litigation orthopedics across the capital, saving 67 millions over a 5-year period. Next slide, please. So this is some examples of what's come out of this program, which we ran starting in September. So on the left there is Barking Havering. They did a surge week, a perfect week they called it. They did 135 joint replacements with a target of 100, 88 day case surgeries with a target of 80, and 27 spinal procedures with a target of 25. But look on the right hand side. This is Croydon doing other specialties as well, but they managed to run through 100% business as usual through 9 theatres rather than 11. So you can see that we can do make massive change if we get things right. Next slide, please. So this should now be the outcome summary slide about what's happened in London. Look on the right-hand side, London is in the blue. The rest of the regions are in the green. Look where we came from on the left, where we were the worst region because we were hit so hard by COVID, round 1. But look where we got to just before the surge that came through in COVID in round 2 in December. And if you look at, next slide, please. If you look at our next slide, both in ophthalmology and orthopedics, look at the orthopedics on the right. The national picture is orthopedic waiting lists are rising, but actually in orthopedics, we've actually got things absolutely spot on the money, and things are were looking really good. Now the next slide should be the data becoming interactive live tool. I note that on the chat box, which appears to be slide behind, it should be showing you lots of green, light red and dark red, and just shows you the average length of stay across the system. This is Southeast, where they have 6 ICSs, and look at the variation across that system that I've highlighted, but that is those are the national 42 systems, and look at the variation. Look at the green line, which is where we want everybody to be, and you can see that there's a lot we can do to improve outcomes. Next slide, please. This is about day case rates. So each of these bars is an individual trust now in London, around the country, and this is how they're performing overall, not just in orthopedics, but across the whole system in day case rates. just look at the variation. And going forward, because we know that with the second round of COVID, we're going to have to do a lot more than 100% of BAU. We're going to have to maximise absolutely to help the day case rates that we can achieve. Next slide, please. What we should now be seeing is an improving theatre productivity slide, because what we need to do is standardise this across London. We can't afford late starts, we can't afford early finishes, we can't afford turnaround times between cases of 50 minutes. What we need to do is be really efficient and really efficient about what we do in terms of our theatre case mix, because it costs about £1,200 an hour to go to work through operating theatres. And once we've got this running, we can then ramp up to 3 session days, 6-day working to improve our productivity. Next slide. This is now the data around a single hospital in the southeast region who returns their data, and we need everybody to return their theatre productivity data. They've got 4 operating theatres, so they have 48 lists a week, but their touch time utilisation, which means when the anaesthetist puts the needle into the patient's hand to start the whole procedure till they come out of recovery, their touch time utilisation is only 52%. They were starting on average 38 minutes late. Their downtime between cases was almost 50 minutes, and their average early finish time was 253 minutes, because they're not using their bed base or their day case rates properly, and therefore they're finishing early. Now, how acceptable going forward is that? So what we need to do is absolutely turn that around. So this is my last slide, which it should be titled the GIRF programme. So the challenge for orthopaedics, we are a massive part of the backlog and the waiting list, up to 20%. And we need to do things differently. We need to transform our secondary care, and we're working well with Andy, both in primary care, about referrals, etc., and about community after discharge. We've got to standardise pathways. We've got to work to the top decile. That's going to be the new normal. And we've got to ensure efficiency through our theatres, and not engaging this process and now is not an option. We've all got to do things differently, and we've all got to own the problem. If we get that right, we free up beds because we're shortening our length of stay. We free up theatre time to do the work, and then we can expand from there to 3 session day, 6-day week working. Let's streamline the whole pathway. We've done a lot of work around secondary care. Let's help Andy do the primary and the community. Let's embrace new technologies about outpatients and follow-up, PIFU, etc., and virtual follow-up by default. And we've got to work in partnership with the independent sector as we move forward to try and sort out this massive backlog. Now, this programme has the support from all: the colleges, the specialist associations, clinicians, patients and politicians. So my plea to everybody on this call tonight is we have all got to own this problem. It's not just the orthopaedic surgeons and the other specialists, it's not just the general surgeons or the ophthalmologists. We all have to own the problem, including the physicians, because when we come to winter and we have long lengths of stay on our medical patients, we can't get them home, then we need their help to free up the bed so we don't stop operating on elective activity during the winter, because only by doing that and working together can we sort out the orthopaedic challenge. Thank you very much.
Thank you, Tim. And we'll move on to the next slide, and we'll just invite Chris to the stage. Welcome, Chris.
Thanks very much. Next slide, please. So now for something slightly different. As Andy said earlier on, I've been asked to lead the restoration optimisation of primary and community MSK provision, which I think is a fantastic opportunity. It feels a little bit on the scary side. Next slide, please. And the next one. I think from a kind of my view of primary and community care is very much a central part of MSK management, and I kind of see it like this: we've got a small amount of primary care surrounded by bigger primary community care. Secondary care is part of the process, but really wrapping around everything. wrapping around all of the care of these MSK patients is what we should be providing is lifelong care, and that includes prevention as well as the treatment. And I think it's something that from the primary and community care setting we can do a lot better. Next slide, please. So, and yeah, if you can just click on through some of these, Rupal, yep, and again, and again, and again. Yeah, keep going, keep going. Next one, one more. So what I've tried to show on here is that trying to separate out primary and community care is a fallacy, because primary and community care wraps around all of the secondary care provision, whether we're linking in with rheumatology program, the orthopaedic program, as Tim's really well described, whether it's diagnostics, whether it's spinal services, fragility and falls, they're all community-based primary care interventions. And even the outpatients optimization program is dependent on a fully operational, integrated primary and community care MSK program. And that's not really what we've got. So whilst these programs, the ones in red, the kind of clinical programs overlap, and they should overlap, we're not quite there at the moment. The two programs here that I've put in green are again areas that I think are the biggest areas where we're lacking in primary and community care. Tim's really nicely described how the GIRFT approach is dependent on data and driven by data. When we go looking for the data in primary and community care, actually we find pockets of good data collection and pockets of patient experience measures and patient outcome measures being applied really nicely, but it's not consistent across the board. And there are no reliable or widely used national data sets for primary and community care, and it's the biggest area where we're lacking. Next slide, please. So whilst I wouldn't say that data is king, I would certainly say that data is key to improving our primary and community care. We don't know what we're delivering at the moment. We think we're doing okay in some areas, and we know we're not doing well in other areas, but we can't actually prove that. So firstly, there's the challenge of us understanding what we're doing and understanding what we're delivering. And then there's the difficulty of benchmarking. So Tim's GIRFT approach is very much based around benchmarking, has had some fantastic results. And I'm not suggesting that we should be completely GIRFT-like, despite all its benefits. I think what some of the stuff we're really missing on is patient experience and patient outcome measures. And I think involving patients and patient groups in our journey in primary and community care is going to be key to developing the service in the right way. And we've had a lot of top-down metrics, but not a lot of bottom-up metrics. And I think that that's really something that we can push towards, and is a great opportunity for us. Next slide, please. So from the introduction that Andy did, he's talked about documents that have been produced early on in the COVID response phase, and this Restoring Primary and Community Musculoskeletal Services Principles document is a key document, and will form the platform for us moving forward with the primary and community care programme. Next slide, please. So what this document does is to build on, as it says in the title, some key principles around delivery of services. So it's not a definite how-to, but it's a document that says this is what you need to consider. And it considers actions for ICS leaders, for leaders at the primary care level, be that commissioners or primary care, network leads, actions for community care services that include diagnostics and the links in with primary care. And what we ask in this document is that there are some measurable indicators to try and boost our data. I'm not quite sure. This is a kind of work in progress document, and I think there are some changes that we can make to the document moving forward with the workstream group. to really try and nail down some of the experience and patient outcome measures. This is available on the Futures NHS website, so the link is on there. So I would encourage you to go to the website, have a look at this document and feedback. And the feedback will be great to get that feedback through the Change Challenge website that Andy talked to earlier, and that will be up and running hopefully in the next couple of weeks or so. So we're looking to really engage and get your feedback on the next steps. Next slide, please. The document is based around some of these principles that Andy talked about earlier. So it's very much around collaboration, and that's around collaboration between professions, between clinicians and patients, and across healthcare settings. So across those settings, we're obviously talking about primary and community care, but also linking those into secondary care. But also let's not forget about the independent sector and patient voluntary sectors. So those are the kind of broader collaborations that we're looking to develop. And as part of that, to co-produce services. I saw in the questions, I think Dale Webb from NAS had asked about involvement of patient groups and voluntary groups, and that's very much what we want to include in the primary and community work stream. We have representation from ARMA and from Versus Arthritis on that group at the moment, as well as links with the CSP, who are doing a huge amount of work with voluntary sector and rehab organisations. So we're going to link all that together. So that's where the integration comes in. We want to work across the boundaries, and part of that working across boundaries is to decide on the data that we want to measure ourselves against, and to share that data. And we know that that's an issue at the moment. And unfortunately, the way that services have been set up over the last 10 years, data sharing has not particularly been encouraged. But hopefully with the new white paper, we can start to break down some of those boundaries. And I'm excited that some of this work, not just in this work stream, but in the other work streams, will help with that data sharing, and we can have some commonality and some benchmarking, which I'm sure Tim will be delighted about. I can see a small nod. Thank you, Tim. And the other thing that this document asks for and pushes is MSK leadership across all levels. So that's at a local, a national, and a regional and a national level. And I think that's again where we're just slightly lacking. So we're pushing to try and get some MSK leadership across all of those levels, so that integration and collaboration is spread across every level. So we get a joined up message. Next slide, please. And I think this is one of my least favourite types of pictures. This is what we commonly see with anybody with a MSK service or MSK conditions trying to promote things. The message from this is everything we don't want to say about musculoskeletal. You know, this is a pain-inducing, fear-inducing, potentially picture. If we go to the next slide, please. This document, Ginda is part of this, the work stream. This is a great document looking at partnership approach for management of musculoskeletal health. I mean, we need to consider musculoskeletal health as a societal problem, not just a healthcare problem. And I think this is about that joining up, health and social care. This is about helping people to manage their own musculoskeletal conditions. Next slide, please. So yes, we do have collaboration from a huge number of organisations. I've put some of them up here, but you can see there's good representation across the professions, with surgical colleagues, rheumatology colleagues, GPs, physios, and various specialities, and radiology, but also patient organisations. And there are more included in there. Health Education England from the kind of workforce point of view. So we're looking to try and integrate, but consider as many aspects of primary and community care as we can moving forward. Next slide, please. So it is a little bit like this, I'm afraid. We're building the plane as we're flying it a little bit with these work streams. And I think, yeah, whilst that might seem a little bit chaotic and, you know, at times possibly feels that way for those involved, it's actually really exciting. And this is a really different way of doing things. It's not driven from top down. This is the collaboration between top down and bottom up. So we're trying to be nimble. We're trying to be flexible. Everybody has a piece of the jigsaw and we're all trying to bring that together to make the whole thing work. Next slide, please. So planes started like this when they started building them. This one flew for about 852 feet back in 1903. Next slide, please. This is one of the latest solar powered planes, and it actually looks pretty similar to the Wright brothers plane. It's not massively different in appearance, but it's much sleeker. It's much more efficient, and I think that's really what we're after from primary and community care for MSK, is to make it much more efficient, make it sleek, make it work better, and produce for everybody involved. So that's where I'm going to leave you, and I think it's over for questions. So thanks for listening.
So I think the next slide is just bringing Andy back for a quick summary and take us into the question and answers. So Andy, back to you.
Thank you, and thanks all. It's been a strange experience watching my phone without seeing any pictures, but actually it's been really, really interesting to follow Twitter at the same time and to see some of the conversation going on. Look, I think Chris sums it up brilliantly at the end, and Tim really focuses the challenge we have ahead. You know, in the context of the restoration, we have a massive challenge ahead. But we had significant challenges before COVID in MSK, and I think what we have now is an opportunity through restoration to try and address those challenges with an improvement strategy. And for me, the ability, you know, our opportunity to have this program and the opportunity that has come through the phenomenal integrated, collaborative, co-produced approach that we've had over the last year is massive. And so whilst we have a huge challenge with regard to backlog and with regard to increased complexity, we have this opportunity to do something different. And I think the only way we're going to achieve this is by continuing this collaborative approach and taking this forward together as an overarching large MSK community, which I've got every confidence we can. And I think this program represents a vehicle to do that. But it's evolving very, very rapidly, and we need to do that together to build what we want to build. And there will be more things coming. And we're putting together common strategies and webinars and discussions, and hopefully we'll not have the delights of the IT failures we had this time to take this forward. And I just really look forward to working with everybody on this over to a few questions, aren't we? Bear in mind, I can't raise the proverbial orange hand or yellow hand because I'm stuck here on a smartphone.
So if you just jump in, Chris, when you want to ask a question, I think we'll all cope with that. Jane, I believe, has sent Tim and Chris an amazing amount of questions that you've popped to us, and I'm going to guess they're not going to get to all of them in the time. So I'll make a commitment for them all that they will look at all of them and come back with a comment of some kind. But in the meantime, Chris, Tim, have you got questions in front of you to answer?
Yeah, I've got one from Louise Warburton. Thanks, Louise. Have you thought of collecting all this work for research? Massive opportunity for research. Yes, and we're looking for partners. Thank you, Louise, for volunteering. I think will be the answer. I think it is a great opportunity to look at how we change, and I think in terms of capturing it, I think things are moving so quickly. It would be brilliant to link up with some academic partners. I know that Keele are doing a lot of work in Nottingham around some of this, so we're planning to link them into our programmes. So hopefully we can do some collaborative work there.
Tim, there's a question on here for you. It's from Anonymous. It says, I noticed on the emergency MSK management document, RCEM wasn't one of the organisations engaged. Can we be assured, with all the work RCEM and ED-GIRFT are doing to avoid ED attendances that work is being done to develop emergency MSK pathways from primary to secondary care, avoiding increasing the pressure on our ED colleagues?
Yes. Can you hear that? The answer to that is yes.
Hopefully that's okay for you there, Anonymous.
I've got another question from Graham Wilkes. Thanks, Chris, for highlighting the independent sector. Pleasure. Can I ask, given the part the independent sector has played in the past and can contribute in the future, how we will be represented in planning and delivering? It's been challenging during COVID to be heard or for offers of help to be considered. So I think, Graham, yeah, hopefully in what I said, it came across clearly that we're looking to collaborate, we're looking to involve all stakeholders. I'm very keen that we link up and link you into the work streams. I don't think any of this we can deliver without collaboration with the independent sector. And as you say, across rehab, across that's pre and post surgical rehab for new technology, etc. Joining up systems, joining up experience measures and outcome measures, all of those things. I think there's good conversations to be had that should be very positive. So I welcome the opportunity, and I'd also just like to say thanks to Louise for volunteering as well. She come back with a yes, she'd like to volunteer. So thank you.
Thanks, Chris. I've got another question here for Andy. It says, great update, really informative. Can I ask, where does pain management sit as part of the MSK programme? Apologies in advance if I've missed this. Andy?
Yeah, no, pain management is absolutely key. If we go back to talk about the MSK matrix, we have got a significant challenge into how, with regard to the condition-specific domain around fibromyalgia, chronic primary pain, non-inflammatory pain, we've got lots of different terminology for it. And of course, we know that painful conditions will be complicated in many because of the pandemic and the biopsychosocial effects that everybody's experienced. So we are going to very much focus on that domain across the model of primary, community and secondary care, but also working closely with the third sector and with mental and social health services. And it's going to be a key focus of our work, especially with regard to the long-term condition management piece, working with our new National Specialty Advisor, embedding that management strategy within a personalised care approach. Now, of course, we've also got secondary care pain management, and we are working very closely with the Faculty of Pain Management and the British Pain Society. But I'm very careful to also remember that a lot of pain management is also not musculoskeletal, and we have to balance that out. Pain management is a critical part of the work we have moving forward, and very much a focal point within all our work streams.
Thanks, Andy. Should we go to one more question then, and then I think the others will pick up offline after the call tonight. I don't know who would like to take this question, but I know it's very close to everybody's hearts and minds. So, has a knackered and bruised workforce been factored into doing this work?
I can come in there. Yes,
thanks, Andy.
Absolutely. Yes, absolutely. This is a pandemic and a year that has been like no other for many of us, that has affected us all, from our occupationally, professionally, personally. We've had to juggle lots of changes in our lives, which have been that have happened very quickly. Many MSK health professionals have been working in different settings, in very challenged environments, and we are fatigued. And the health and well-being of our workforce is absolutely critical, because we've got another challenge ahead. But we've got to balance that with the fact that as a workforce collectively, we are fatigued and it's been hard. So it's absolutely being factored in to the work we are doing. It's absolutely key.
Can I just also add in for Tim Briggs here from the secondary care sector? If you look at, again, what's happened to staff with redeployment, both in theatre staff, allied health professionals and clinical staff, into the workload to manage the COVID. Absolutely right, people are tired. What was interesting after wave 1, when we got going in London, was that when people got back to their normal day job, they were able to do the work they were doing before COVID, such as Swelliok and the hub sites, what have you. It was amazing how quickly morale rose when they were getting back to doing the job they really wanted to do and they loved. We know that we are, as we restart in London, we're certainly not going to get going until April to give people a rest as the COVID surge comes down and becomes more manageable. But I think we all have to realise that at some point we do have to deliver for our public again on what we're doing. But absolutely right, if we don't have the workforce in place, we don't look after the workforce, then we're going to achieve nothing. And we are absolutely all aware of that and committed to looking after the workforce, I promise.
Yeah, I couldn't agree more. And as a still working clinician and a team lead, you know, I'm concerned about my team or the team that I work in, and the teams in the community. So I think we need to take this slowly, but it's a great opportunity for us to change things as we move forward. But I think doing that together in a collaborative way will help, and it will help build on some of the collaborations we've made during our redeployments in COVID. So I think there will be some positives to come from that. But I'd agree with the sentiment entirely. We need to look after the workforce going forward.
So I've just had a little message that's come through to my phone, accepting I can't see anybody, that it's time for us to wrap up. And I'm very conscious that we've dragged this webinar on longer than a lot of people were expecting due to the IT issues. So for those of you, and I understand it's many of you who have joined, thank you. Thank you for putting up with us, and thank you for listening to our presentations. I've had a number of requests through social media about recording and sharing this. Absolutely, we will do that, and we will share it hopefully in the next few days, and we'll also reflect on the questions. And to reiterate, you know, we've a challenge ahead, but we've got a great opportunity here, and I think I can speak on behalf of Tim and Chris to say we all look forward to working with you on this. So thank you for your time and have a lovely evening.